Good morning, everybody, and welcome to Georgia Heart Grand Rounds. Thank you all for joining us today. This program is brought to you by Georgia Heart Institute and the generosity of grants from our industry partners. The planners and speaker have disclosed no relevant financial relationships with commercial interests. I'm also pleased to share that today's event has been awarded credit for physicians, radiology technicians, and EMS. Please make sure you sign in so we can track your attendance and you can receive credit for today. If you are on the Zoom, there is a link in the chat for you to sign in so we can capture your full name and track your credit for CME. And now, Dr. Samity will introduce our guest, Dr. Robert Bonow. Thank you.
Good morning. Welcome to Cardiovascular Grand Rounds. It's really a unique pleasure, singular honor to present this morning's speaker. Dr. Robert Bonow is a distinguished Goldberg Professor of Cardiology at Northwestern University, Feinberg School of Medicine. He served as a senior investigator in the cardiology branch of the NHLBI from 1980 to 1992. And he was chief of the Division of Cardiology at Northwestern University and Northwestern Memorial Hospital from 1992 to 2011. Well, Dr. Bonow, I will say, is one of those icons in cardiovascular medicine that most of us, even during our training, learned from. And I personally would put him in the category of Dr. Eugene Braunwald, as well as other master clinicians who've really shaped the field of myocardial hemodynamics, valvular heart disease, and our early understanding. He's co-authored over 650 papers, 120 book chapters, and is currently the editor-in-chief of JAMA Cardiology, as well as the editor of Braunwald's Heart Disease, a textbook of cardiovascular medicine. He's former president of the American Heart Association, a master of the American College of Cardiology, as well as the American College of Physicians. And he's obviously served on numerous advisory boards, including with the NHLBI, the board of the trustees of the American College of Cardiology, as well as the board of directors of the American Heart Association and the subspecialty board on cardiovascular diseases of the ABIM. As you might expect, he's the recipient of a number of distinguished awards, all of which cannot be disclosed, and we don't have time, but I would focus on the Distinguished Achievement Award, the Gold Heart Award, and the James Herrick Award of the American Heart Association. He's also received the Distinguished Service Award and the Distinguished Scientist Award of the American College of Cardiology, and the Denelin Award of the European Society of Cardiology. I think most importantly, as we caught up at dinner last night with Dr. Henry, Dr. Cheneretti, that he's still extremely passionate about teaching. And as he was telling me, in addition to the work that he does with JAMA Cardiology, which is now one of the main journals in cardiovascular medicine, he takes a lot of joy in teaching fellows and spending time with them. I personally, my career was inspired by the work that he did. Some of the early work we did when I was a fellow was inspired by some of the leadership and work he's done in valvular heart disease and myocardial viability and many other areas. So it's really a great honor that he's joined us. And today he's going to talk to us about aortic valve disease, new insights, new options, new challenges. Please welcome Dr. Bonow.
Well, thank you very much, Dr. Samity. It's great to be here. And it was kind of fun, interesting to get together last night and talk about how our lives have evolved from our earlier stages. And that's kind of what I'm going to get into this morning, kind of how my work evolved too in this particular area of aortic valve disease. I have no relationships to disclose other than this is an area of interest of mine. And therefore, I thought I could kind of flip the discussion about what's happened in my career in the last 50 years or so on what we know about aortic valve disease and where it's going. Not so much where it's been, but where it's going. And to start with that, I'll talk about my experience in medical school. So first, in my third year, I had my cardiology rotation. And my first patient at the University of Pennsylvania was a patient with aortic stenosis. So what does a third-year medical student do when confronted with a patient with a disease? You go back to your first-year medical school notes. And I actually had these notes. I told Dr. Samity last night, my wife and I were downsizing our house. We had this big old house, too many rooms. Kids were been out for decades. So we had to clean house. And so I went through my files and I came across these 2 pages. And they look familiar to most of you, even though they were not PowerPoint slides that we now hand out to our medical students. But even back then, as a first-year student, I was learning things about volume overload, pressure overload, Laplace relationships, how that might, in some patients, lead to left ventricular hypertrophy, which may be good for a while, but not good for the long term. But then the real thing, when I started looking at this again, was looking at this. In fact, there was one reference here, just one reference. And so I had that one in the file too, from 19 whatever. And so I pulled that reference out, and bingo, this is what actually turned my life around. It's a single manuscript. It was the only reference that the medical students were given from a group at the National Heart, Lung, and Blood Institute. It was then the National Heart Institute. And if you anyone in the audience who's of the right vintage will recognize a lot of these names here. Andrew Morrow, William Roberts, John Ross, of course, Eugene Brownwald. It's kind of a gas house gang of the leading figures in the field. And Dr. Morrow was a surgeon. He actually created this whole thing. He recruited Dr. Brownwald and gave him the playing field to prosper. And this was a paper about left ventricular outflow tract obstruction. This group was prolific. They were putting a manuscript into the medical literature like twice a week for decades. And so when I read this as a medical student, it kind of flipped the switch for me. And I said, I want to be like those guys. And so that's what I did. I actually applied to the NIH. It was the same program that Dr. Brownwald had gotten into. And this was Building 10. It was a big clinical center. If you've been to the NIH recently, you realize there's no green grass anymore. It's all been asphalted over. The tennis courts are gone, and they've become either a building or a parking lot. But what I got into was interest in aortic valve disease. And so my first couple of manuscripts there were related to the use of echocardiography, a new tool back then. And what we had was M-mode echo, to study not so much a diagnosis, but using that as a clinical tool to start describing patients and their outcomes. And some of the authors here, again, were Dr. Morrow, my mentor, Dr. Epstein, and Walter Henry. And we were able to use this tool to start studying things, like for aortic regurgitation. What are some prognostic factors? Left ventricular ejection fraction. And another measure of pump function would be end-systolic volume, or in this case, end-systolic dimension or diameter. And using the same echo techniques to look for left ventricular hypertrophy and aortic stenosis and how that regresses after aortic valve replacement. Dr. Henry moved on, became chief of medicine and ultimately chancellor at UC, in one of the California state's universities. And Dr. Morrow tragically died in 1982, but I stayed with Dr. Epstein for about 16 years, as Dr. Samity indicated, and it allowed us to do some longitudinal studies using echocardiography to identify the natural history of aortic valve disease, in this case, aortic regurgitation. We're using a echo to measure the end-systolic diameter, which is kind of a neat parameter because it encompasses both the volume load of aortic regurgitation and also the shortening that occurs. and it could identify asymptomatic patients and their progression over the course of time in the natural history related to the end-systolic dimension, and even following that out for longer periods of time in the same patients, followed for over a decade. And so the end-systolic dimension became a kind of a tool that a lot of other people got into. And if you've been following this, you'll realize that that's actually in our guidelines even now. We've had guidelines since 1998 for valvular heart disease. A lot of those have changed a lot because of all the new things that have happened in valve disease. What's remarkable is how little has changed for aortic regurgitation. So symptomatic patients would be a class 1 indication. For asymptomatic patients, the indications for aortic valve replacement would be left ventricular systolic dysfunction. That's defined currently as an ejection fraction less than or equal to 55%. And then if you have patients who have severe left ventricular dilation, and bingo, here's the left ventricular end systolic dimension of 50 millimeters, something that we were studying 30, 35 years ago, still there as an indication for intervention in asymptomatic patients if there's an end systolic dimension greater than 50 millimeters, or that could be indexed to body surface area of 25 millimeters per meter squared. We'll come back to that in a few minutes. And you have some patients who have severe volume load in the ventricle. They still have a good systolic function, but really enormously dilated left ventricles, especially young people who may have bicuspid valves and aortic regurgitation. So even if systolic function is normal, but you've got progressive enlargement of the ventricle, there's kind of a arbitrary threshold here, totally arbitrary, where you might consider as a class 2B indication intervention. But what do we know about some of these indices? These are all based upon no prospective randomized trials. There's no class 1 level of evidence A recommendation here. They're mostly observational, retrospective analyses that I've contributed to, and we're aware of all of the shortcomings and the warts associated with studies like that. This one is based upon a single study from the Mayo Clinic. It was replicated by some other data from a different center, just showing that you could index this. But we all know that indexing anything, measure we have in cardiology, according to body surface area, is not perfect, including this one. And so if you've been following this field, you realize that a number of papers have been published in the last couple of years challenging that 25 millimeters per meter squared threshold of end systolic dimension. How much shortening do you have during systolic function? And there's been 5 of those. I'm just showing the first 3 here, one from the Cleveland Clinic, one from the Mayo Clinic, and one from a group of investigators in Belgium, where the red line here is the guidelines recommended threshold, 25 millimeters per meter squared. And we're looking here at the clinical outcomes of patients, which is mostly death. On the right is death or heart failure. And you notice that the uptake in bad outcomes occurs at a much lower threshold than 25 millimeters per meter squared. And so you could argue that perhaps what worked years ago when we were first learning how to use these techniques, and patients were sicker before we recommend surgery, perhaps now in the current era, we should be using maybe earlier intervention and lower thresholds. But the thing for me is, why are we still doing this? Why are we 35 years after people started looking at the unidimensional measurements? Why are we still using linear dimensions in 2024 instead of using left ventricular volumes? Because the ventricle can dilate in various shapes and sizes. It could dilate as a sphere, or it could dilate as an oval. So just looking at the linear dimension of that chamber is fraught with hazard. So why don't we have other indices? So I had the opportunity to write a editorial back when Jagat Narula was the editor of JACC Imaging. And I notice you have Dr. Narula coming here a month from now. So that's a must attendance for all of you, because we'll give you a great presentation on plaque vulnerability and patient vulnerability. But it was given the opportunity to write an editorial, and I said, okay, why are we still doing these linear dimensions? Why can't we move on to more quote unquote modern techniques where the left ventricular volumes, how about interstitial fibrosis from cardiac magnetic resonance imaging, GLS, global longitudinal strain from echocardiography, how about biomarkers? Why can't we let the ventricle tell us when it's thinking it's working too hard and putting out too much BNP or maybe other biomarkers as well? And what's sad is that very little has changed since I wrote this in 2011, but we're starting to gain some ground and gain some momentum because now there's some new data to talk about. For example, there are data on left ventricular volumes, the end systolic volume as opposed to the end systolic dimension. There's one study from the Mayo Clinic by Young and co-workers showing that if you look at the left ventricular end systolic volume relative to outcome, and the red line here would suggest what the ASE, American Society of Echo, tells you should be the upper limit of normal. Somewhere around 45 milliliters per meter squared is where you start seeing a signal of an adverse outcome. This is using echocardiography, either 2D or 3D measurements of end systolic volume. That was replicated in a study using magnetic resonance imaging by Hashimoto and co-workers working with João Cavalcante in Minnesota. So it's a different technique. It's MRI, but looking at the same kind of indices of end systolic volume, showing that there's a adverse outcome once patients have an end systolic volume over that same threshold, 45 ml per meter squared. And so when they dichotomized the data and looked at those with a volume greater than that or less than that, they're able to show the survival curves diverging significantly. You gotta be careful with data like this. These are all observational data, especially for MRI. Every patient gets an echo. When you start looking at the MRI data, one of the first questions should be, okay, who are these patients? I mean, how many patients with aortic regurgitation go for MRI? It's probably a subset of a larger series. And so take any data like this with some degree of appropriate, inquisitiveness and skepticism. So the curve on the right, the curves on the right from the MRI group show clearly that the end systolic volume index of greater than 45 ml per meter squared was associated with a worse outcome. Now, these were ostensibly asymptomatic patients with normal left ventricular ejection fractions. Okay, very important message. But look at that orange curve. A lot of those events occur in the first month or two. So were these really asymptomatic patients? Were these patients already destined for surgery who happened to get studied early on before they had operation? You see the same thing with a series of patients from a multi-center group looking at the end systolic volume index as well. And so again, there's a worse outcome in patients who have a larger end systolic volume, but a lot of those events occur really early. So were these really asymptomatic patients? What was the referral bias to get the MRI? It'd be nice to have a prospective registry of patients going forward who are not so much, have as much of a selection bias. Now, the other thing about MRI, which is important, of course, is that when you started adding other indices from MRI, like the regurgitant volume, regurgitant fraction to the end systolic volume, you could also get even a tighter signal regarding which patients are at risk for a worse outcome. Now, what's interesting for me, again, going back as to what I learned in my early years, is that we had evidence of that in 1980 from a series of patients studied at the Peter Ben Brigham Hospital, which is now Brigham and Women's, from Bonow and co-workers, Bill Grossman. They had patients who they evaluated after aortic valve replacement. That's the postoperative change in the ventricular volume, as opposed to the preoperative end systolic volume index. And if you look at where their cut points are, when you had an end systolic volume index greater than whatever, in this case 30 to 60 ml per meter squared, this really had less of an improvement in left ventricular remodeling after operation. This one didn't catch on because this was using left ventricular angiography. And so you can't use that over and over again in serial studies, which is why this never really caught on and why we started using echo and its linear dimensions. But now we've got the tools. And now we should use those tools to begin to study these patients non-invasively and try to get better outcomes, better measures of outcomes so that we can tighten up our indications for when to intervene. The other thing about aortic regurgitation, which is important, is that we know it's a lesion of preload because of the volume overload. It's also a condition where you have increased afterload because of the wall stress imparted upon that ventricle because of the regurgitant volume. And that wall stress has to be overcome in order to shorten. And that creates an afterload effect. And so it's really an interesting condition where the preload is related to left ventricular volume, but the afterload is a stimulus for left ventricular hypertrophy. And therefore you have incredible increases in left ventricular mass in patients with aortic regurgitation. Even bigger masses than you'll see in patients with hypertrophic cardiomyopathy. This big ventricle, when you blow up a balloon, the wall gets thinner. But when you dilate the ventricle with aortic regurgitation, the wall gets thicker. So you have incredible increases in left ventricular mass, meaning that perhaps we should be looking for other indices of the left ventricular overload beyond simple measures of volume or function. How about interstitial fibrosis? We're beginning to get some data from that, from MRI studies. The information is still very early in the game, but we're beginning to see some indications using MRI for myocardial fibrosis, interstitial content beyond the myocyte volume. And we could also use echo using global longitudinal strain, which gives us some similar measures regarding what the myocardium is going through. Here's one series, or many others out there. This one from Cleveland Clinic by Alashi and co-workers, using global longitudinal strain to look at outcomes in patients with aortic regurgitation. This is all patients on the left, but more importantly on the right. They divided the patients into those who were going for surgery on the bottom versus those who did not have surgery. And so a GLS here of around minus 17, 18, or 19 begins to identify patients who may have a worse outcome regarding the true left ventricular functional state that's kind of less load dependent than something like ejection fraction. And so finally, we have a synopsis that was put together last fall as a state-of-the-art review. The first author here was a really talented fellow from Columbia, Lauren Renard, where we tried to crystallize what's got to be done in the future to identify what the thresholds may be for aortic regurgitation. And so suggested novel markers, and these are not yet worth being used for prime time, but there's kind of signals beginning to get regarding when there may be patients who are kind of exceeding the safe thresholds and should be maybe sent for earlier intervention. What we need are more data to support this, but these are novel and they're evolving. And systolic dimension index perhaps being lowered to 20 ml per meter squared, and systolic volume index from either echo or CMR, global longitudinal strain from echo or CMR. And then some more unique things you get from CMR, like the regurgitant fraction, very accurately measured, and the extracellular volume using contrast imaging with MRI. So stay tuned. I think these are evolving and hopefully going to be helpful in our patients with aortic regurgitation. We haven't come that far in this field, whereas we've come very far with aortic stenosis. I'm going to shift gears now and spend the rest of the time talking about some of the more exciting things with aortic stenosis. So when I was training, we thought the valve that became so severely calcified became calcified through a process of essentially wear and tear. It's like a rusty gate left out in the rain, and ultimately it becomes really tight. We now know that's not the case. We have good epidemiologic studies from Framingham, from the Canhart group in Ottawa, from Ontario, where every patient in Ontario was in a database, showing that some risk factors like diabetes, hypercholesterolemia, hypertension are risk factors not only for coronary disease, but also for aortic stenosis, suggesting that this is not a passive wear and tear, but more of an active, proliferative, and maybe inflammatory lesion. And indeed, it appears to be. For example, we have PET CT studies from Mark Dweck's group in Edinburgh, showing that you use a CT to identify the calcification, obviously, and then the PET studies could be used to assess two things. It could assess microcalcification using sodium fluoride, F18 sodium fluoride, or inflammation using F18 fluorodeoxyglucose. So here are three patients from their series: a normal individual, patient with mild AS, patient with severe AS. And so the patients who have the severe AS not only have more calcification, but also have indices of greater inflammation as well. This was a cross-sectional study, but they came back with some longitudinal data in patients. And here's two patients in a series they had that studied a baseline showing a little bit of calcification on the left panels, but a significant amount of FDG uptake suggesting inflammation. And when these patients were studied a year or two later, those areas of inflammation had indeed progressed to greater calcification, suggesting again that there's kind of an inflammatory process going on in some patients' aortic valves that can lead to signaling leading to calcification. And indeed, one sees indices of inflammation also in valves that have been explanted at surgery. This study by Mahmoud and co-workers looking at valves taken from patients with aortic stenosis undergoing aortic valve replacement surgically, looking at a upregulation of lipoprotein-associated phospholipase A2. Phospholipase A2 is an enzyme that hydrolyzes lipoproteins into fatty acids and oxidized phospholipids. And so what one sees here are indices of upregulation of this enzyme on the left and the content of oxidized phospholipids on the right. And so a signal here also regarding inflammation. And then the final piece of the puzzle is the potential genetic aspect of this as well. This is a large GWAS study. You may have seen this. It has been cited and replicated numerous times from George Thanasoulis and a large number of co-authors around the world. It's about 45,000 patients in a validation and replication cohorts, where they found a single SNP sitting on chromosome 6 that is associated with the development of aortic valve calcification. This SNP sits in the locus of LPA, the gene that codes for circulating levels of Lp(a). And so the suggestion was that individuals at risk for high Lp(a) may be patients in whom one would see a development of aortic valve calcification. Again, this has been replicated numerous times, including a study from Denmark. Again, a country where we have lots of good data in most of the citizens in the country. And so this is a series of thousands of patients in Denmark looking not so much at aortic valve calcification, but the development of aortic stenosis over the course of time. And if we look at the left, these are the Lp(a) levels. And when you have a Lp(a) percentile in the ballpark of 63 milligrams per deciliter or greater, the risk of developing aortic stenosis is significant in a multivariable adjustment. And interestingly, they also had genetic data in these individuals. And what's plotted here are the levels of the number of patients, the number of individuals who had that gene variant we talked about on the previous slide. So the number of individuals who have the Lp(a) in the 90th percentile or greater, about half of them are kind of genetically predisposed to this by having that SNP variant that was discussed earlier in the large GWAS study. And so the scenario might be something like this, that LP little a into the intercellular space can be cleaved by the phospholipase A2 into oxidized fatty acids and also into lysophosphatidyl-choline, which is a very strong inflammatory stimulus, recruiting macrophages, which then through a series of signaling can hit the valve interstitial cell, transforming its phenotype into more of an osteoblastic phenotype as well. So that's a simple, cartoonish way of looking at what could be going on in terms of the reason why patients develop aortic stenosis. Of course, it's too simple. A more complicated way of looking at that, kind of like the New York subway map, is shown by Brian Lindman, where we've only been talking about the left side of this over here, is the lipid infiltration and the oxidation of phospholipids. But then there's more inflammatory markers, and there's also other markers that can lead to a fibrocalcific response. The reason we're getting into this is that in this mix of signals, there's got to be a druggable target here. There's got to be perhaps a medical therapy that could slow down this process or maybe even halt it. And we're not there yet, of course. We know the statins are not effective. We're really interested in what the coming pipeline of drugs that lower LP little a might deliver in terms of the changing natural history of aortic stenosis. And so in the future for the fellows, first of all, this is good research you could get into, trying to identify which of these processes might be druggable. But also in our future, we're probably going to have medications that can slow down this process. But let's think about not only medications on the valve, but how about medications for the ventricle? Because this heavily stenotic aortic valve is doing something to the left ventricular myocardium also. Left ventricular hypertrophy in aortic stenosis is obviously a marker of the severity of pressure overload. It's a compensatory mechanism to reduce the wall stress in the setting of pressure overload. But like any compensatory mechanism, it's a good short-term fix, but it has long-term adverse consequences. Because this could lead to a more myocardial stiffness, increased LV end diastolic pressure, left atrial pressure, giving you a HFpEF phenotype in our patients. So, a lot of patients with symptomatic aortic stenosis have totally normal ejection fractions, but they're short of breath. And this because they have severe left ventricular hypertrophy. And it could also be a contributor to adverse outcomes. Now, we used to study this in very interesting ways because we couldn't look at the interstitial content other than doing a myocardial biopsy. And indeed, a series of investigations from Hessen Kreinbuhl and co-workers in Zurich were doing serial left ventricular biopsies in patients with aortic stenosis before and after aortic valve replacement. They showed that after the aortic valve replacement, you have reduction in left ventricular hypertrophy, so the myocyte volume diminished. But the collagen, once cross-linked, is usually there to stay. And so these patients actually had stiffer ventricles post-op than they had pre-op because the percentage of collagen per myocardial mass actually increased. So we don't do that anymore. We don't do biopsies, but we do magnetic resonance imaging. And we're going to begin to identify fibrosis in patients with aortic stenosis as a marker of adverse outcomes. It's been shown by numerous investigators. Again, I'm showing data here from Mark Dweck. The reason for focusing on the Dweck studies is that they also had a lot of interesting data that's been coming out, both as cross-sectional data and also longitudinal data. The one I see is most interesting is from Chin and co-workers looking at a series of patients with aortic stenosis, those who all are undergoing magnetic resonance imaging. And so you have three groups here, one with normal myocardium content, the group on the right, patients who have frank replacement fibrosis with late gadolinium enhancement, and in the middle, patients who have an increase in extracellular volume using T1 mapping. So they have three groups of patients. As you'd anticipate, the groups going from left to right would have more severe aortic stenosis, so the peak aortic velocity is greater to the right. They have greater left ventricular mass, more left ventricular hypertrophy. That indeed does lead to left ventricular diastolic dysfunction, increasing from left to right. And for me, the most interesting feature they had was the fact that there also is a troponin leak. So the patients who have the more severe stenosis, more severe hypertrophy, more left ventricular mass, are also leaking troponin. That's probably why they have the replacement fibrosis, because there's been injury to the myocardium. And so this, I think, leads to some other thoughts about what LVH could be doing in patients with aortic stenosis. It creates the diastolic dysfunction we've been talking about. It can lead to interstitial replacement myocardial fibrosis, which makes the diastolic dysfunction worse. And then you can also develop microvascular disease because of the left ventricular hypertrophy, which then can lead to myocardial ischemia, which will signal back to, again, increase the left ventricular diastolic dysfunction through an ischemic process. And so, again, other thoughts about where this could go in the future in terms of maybe therapies to reduce some of these processes from occurring. And so if we're talking about medical therapies, it's not only to reduce the development of aortic valve calcification and its progression, but also perhaps some therapies to treat and protect the left ventricle. A lot of this has been summarized very nicely by a review article from Catherine Otto, which is now 10 years old. It's still, I think, must reading for our fellows in terms of the patients at risk for developing aortic stenosis, the progression of this disease, how to image it, when to image it, and also when to intervene. The must-read article for me, when I was a fellow, was this manuscript from Ross and Brownwald in 1968. Now, whether you know it or not, you have seen this study before. And if you actually go back and find it in the literature, you realize it's essentially a research letter. It's 3 pages, but it's the seminal paper from Ross and Brownwald that gets into the whole concept that once patients develop symptoms, they have a bad outcome. The gray prognosis, it appears to accompany the onset of certain symptoms. And the reason I know you've seen this before is this is where the seminal diagram comes from Ross and Brownwald, which everybody shows when they give a presentation on aortic stenosis. Some interesting things about this figure. First of all, it's a schematic. This is in their heads. These are not actual patient data. And if you look at the paper, this is all based on 12 patients. 12 patients. And if it looks like it's been drawn on the back of a napkin, that's how it actually happened. This happened because the surgeon I mentioned before, Andrew Morrow, who was really the ringleader of this group at the National Institutes of Health, came back to Dr. Brownwald and said, what are you guys doing? You're suddenly these patients with aortic stenosis. Is it too early? Is it too late? What do we actually know about the natural history? And when is the right time for me to be receiving these patients from you guys? And so literally, Dr. Brownwald and Ross in Dr. Ross's kitchen sat down and tried to figure this out. And it may not have been a napkin, but they drew this schematic about the natural history of increasing overload of the myocardium. The patients do okay with compensation until symptoms happen. And then when symptoms happen, you have this very rapid fall off where about 1/2 of the patients will die over the course of the next 2 to 3 years. So this was in 1968. In 2018, the 50th anniversary of this figure, we had a symposium. Dr. Brownwald was there. We talked about this figure. He gave talk about the history. And I kind of needled Dr. Brownwald, unfortunately, at the podium. And I said, Dr. Brownwald, it's unlikely that any of your TIMI trials, where you've got thousands of patients and seminal observations from clinical trials, will have the staying power of this figure and the longevity of it, because this has stood the test of time over the course of 50 years. So the other remarkable thing about this figure, number one, of course, is our patients are getting older, but we still see the same phenomenon. A symptomatic patient at age 85 or 90 will have a bad outcome if not intervened upon. And then the most remarkable thing is that it's been proven true, that patients with symptomatic aortic stenosis who do not undergo aortic valve replacement have a particularly poor outcome. And this paper by Bach and co-workers, which was published 40 years after the Brownwald and Ross paper, showed that in symptomatic patients without aortic valve replacement, 50% of the patients were dead within 3 years, exactly as predicted by the back of the napkin scenario that we discussed about 40 years earlier. And so that kind of makes it easy for a guidelines committee that I've been a co-conspirator with for several iterations, that one would always recommend intervention, replacement of the aortic valve, and most patients have symptoms. So it's easy to write that, and for the fellows, that'll be a easy one for your board exam. So you answer this one, yes, we did intervene, and then go on to the next more difficult question. But in clinical practice, this is not so easy. I mean, is it likely that these symptoms are cardiac in origin? If your patients are like mine, they're deconditioned, they're overweight, they're not used to exercising, and they're a little bit short of breath. Now, is that a cardiac symptom or is that a lifestyle issue? This kind of gets messy when you're talking about trying to use very simple recommendations in your clinical practice. And the other one is the flip side of that, are how many of your asymptomatic patients with aortic stenosis are really asymptomatic? The patients downgrade their activity level when they're getting short of breath. They're playing 9 holes of golf instead of 18 holes of golf, et cetera. Are these patients really asymptomatic? Well, we recommend perhaps in an asymptomatic patient, let's do a stress test and prove that the patient is asymptomatic. But if you've got an elderly individual who's deconditioned, may have orthopedic issues, and not used to exercising, put them on a treadmill, and that individual goes 1 minute on the Bruce protocol and is short of breath. Is that a cardiac endpoint on your treadmill test, or is that, again, a lifestyle issue? So these things are quite complicated. So the real issue is, are asymptomatic patients really asymptomatic? And what are the outcomes when we have data in patients who we think are truly asymptomatic, but with severe aortic stenosis? Here we've got some good natural history data from a number of series, all kind of pointing in the same direction. This is defining severe aortic stenosis as a peak velocity across the valve of 4 meters per second. And in these 5 or 6 series, you find that not everybody, but most everybody, will have an endpoint over the course of the next 5 years. Most of the endpoints, in fact, the vast majority of the endpoints are not death. It's patients developing an indication for aortic valve replacement because they're developing symptoms or having other things going on that would want you to recommend an aortic valve replacement. Wouldn't it be nice to have a randomized clinical trial that shows that early aortic valve replacement in asymptomatic patients with severe AS improved survival? And we were looking for those for years, and now we have 2. We have the recovery trial from Korea and the Avatar trial from Bonow and co-workers in Eastern Europe. Both published very recently. A very similar design, relatively small series, 150 such patients in both with severe aortic stenosis. The group on the left, a little bit younger with bicuspid valves, group on the right, also with severe aortic stenosis, but in the European study on the right, every patient had a treadmill test and could achieve 85% of maximum predicted heart rate without symptoms. So they probably were truly asymptomatic. And if we look at the outcome data, a few points here, both studies showed better outcome in patients who were randomized to early surgical intervention, the lower curves. A few points about the one on the left from Korea, showing a much better outcome with early surgery. In Korea, they had very few patients with diabetes, peripheral vascular disease, or coronary disease, so it may not fit a US population. But notice that there is no deaths in patients getting surgery out to 3 to 4 years. So could you guarantee your patients undergoing aortic valve replacement that it would have a survival of 100% for the next 3 years? So there's probably a difference in the patient populations in that study. The other thing is in patients who were randomized to conservative management, where we would wait until there was an indication for a valve replacement and then replace the valve, they had a 26% mortality in 6 years in these patients, initially asymptomatic. So the question here is, okay, who is following those patients? Were these patients followed carefully enough to know when they were starting to develop symptoms or more severe aortic stenosis? And so, again, I have some concerns about the generalizability of these data to the patients you and I see. The one on the right was a little bit more like a Western countries' population from Eastern Europe. This one also had some issues. They have 157 patients in this series using a composite endpoint of either death or heart failure or stroke. Luckily, there were very few strokes, so it's mostly death or heart failure. Composite endpoint, 157 patients, but this was powered for 310 patients. It was terminated prematurely in the fall of 2020, probably because of COVID issues, where they had trouble enrolling patients. And so it was closed prematurely. They still showed a significant benefit, if you will, of early surgery in blue using this underpowered study. When they looked at survival alone, they found that this was not significant, although there is a signal there. The other aspect of the AVATAR trial on the right is that 115 of 157 patients, about 80%, were enrolled at a single center. So you worry about multi-center trials where most of the patients come from one place and not the other multi-center institutions. But anyway, there's a signal here that this may be beneficial for us. So what do I do then when I'm confronted with patients you and I see? 84-year-old man, severe aortic stenosis, a Vmax of 4.5, a mean gradient of 42 to 48 millimeters of mercury. We could do watchful waiting. We could do more data, more testing, stress test, BNP. We could just replace the valve now. None of those would be wrong, as long as we're doing the next best steps after we check one of those boxes. Watchful waiting has a new connotation. It's really not watchful waiting. It's waiting until the patient develops symptoms, because we know it's going to happen from those natural history data within 4 to 5 years. And that means the patient can now have a TAVR, because right now we would not recommend a TAVR for asymptomatic patients. And Medicare would not pay for it unless the patient has symptomatic aortic stenosis. And the patient would like to wait until he or she is a candidate for a TAVR also, of course. And so watchful waiting has a different connotation in the current era. But what I did was I enrolled them in a clinical trial. And the early TAVR trial of asymptomatic patients with aortic stenosis getting a TAVR will be presented this fall. So we'll finally have some really good data in a larger series of patients with no symptoms undergoing a less invasive procedure. So stay tuned for that one. That could be totally game-changing, if you will. So what are our knowledge gaps with aortic stenosis? The symptomatic patient, are these cardiac symptoms? The asymptomatic patient, are these truly asymptomatic patients? What are the mechanisms of inflammation and calcification? If we can understand that, there may be drug therapies. What are the role of biomarkers? Not just BNP, but other markers of fibrosis and inflammation, perhaps. I'm not getting into the whole issue that you and I deal with day in and day out with low gradient, low flow aortic stenosis. That's a lecture unto itself, other than it's difficult, especially the patients who have paradoxic low flow, low gradient, with normal left ventricular function. There, what you need to do is put your thinking cap on and try to sort out as best you can what could be true aortic stenosis versus more of a HFpEF phenomenon. And then finally, let's talk about TAVR, the evolution of TAVR to lower risk patients. So we're starting to grapple with this one because of our indication creep. We do know from the STS data that the volume of TAVR procedures eclipsed surgery right around 2017, when the low risk trials were published from both the Evolut group and the Sapien group in the clinical trials. And notice that that's when the surgical volume also declines. So initially, the TAVR volume was taking up those patients who were not undergoing surgery. So surgical volume did not change much. But then in 2017, when we started doing TAVR in lower risk individuals, that's when you see the surgical volume begin to decline. And that obviously is carried forward into the 2020s as well. I'm sure that's the case in your institution. Most of our aortic valve replacements are now done with TAVR, unless you're dealing with younger individuals or individuals who have other conditions that also need surgical attention. And so what does aortic stenosis say? Not so much when do you want to intervene, but what are you going to do in the intervention, SAVR versus TAVR? The most important thing is shared decision-making, so that we're talking with patients and their families and what they want, as well as what we think would be best for them. We do recommend surgical volumes, surgical replacement, SAVR, for younger patients, less than 65. TAVR is preferred for older individuals greater than 80, whereas one has more of a important discussion in those individuals in that intermediate age group, 65 to 80. The European guidelines have different thresholds. I'm not going to get into that one. You could argue why they have different thresholds. They use 75 years. Using, they have the same data we have, but that group decided on a lower age, and also a higher age before you would consider TAVR in patients with aortic stenosis and recommend surgery for younger people. But the key here is this is what we say we should be doing for people less than the age of 65. Well, here's some data that you may have seen by Sharma and co-workers in Vermont, looking at the national data in academic medical centers over the course of years. So the color code here is different years from 2015 to 2021. And they've got 3 age groups under the age of 65 where we do not recommend TAVR in the guidelines. You find that by 2021, half of the patients in academic medical centers, where people probably have read the guidelines, are still performing TAVR in people under the age of 65. Now, is that wrong? That the doctors are extending their experience and their expertise into younger individuals that would be inappropriate? Or maybe this is really appropriate. They've talked with their patients. What do the patients want? Because again, if shared decision-making is a class 1 indication, you and I grapple with this all the time. And it's not just an issue for the 64-year-old who's almost 65, but what do you do with the 60-year-old patient or the 55-year-old patient? We grapple with this because every patient wants to have a lower risk procedure. The issue with the younger patients, of course, is not only durability, where you need to consider the lifetime issues of aortic stenosis and what would be your next procedure in a younger individual where you know the bioprosthetic valve may or may not last over the course of decades. And also the issue of pacemaker rates, which is not so much an issue for a 95-year-old as it would be for a 55-year-old. So the challenge is in 2024 is that the threshold is declining in clinical trials, registries, and clinical practice, evidence of an indication creep. The heart team is really essential here in pulling together the data, identifying patients who are candidates for TAVR, and then working with the referring doctors and the patients into a shared decision mold to try to understand what's going to be best for that individual patient and what does the patient want. But the challenge for you and me is that all patients want TAVR, understandably. And therefore, the most difficult thing we do is when to tell patients we think that's not a good indication, either because they are so sick with comorbidities, kind of the group 3 individuals and partner, where even intervening is not going to lead to a better outcome in terms of quality of life or survival. And saying no to some people who have older age and more comorbid conditions, but also the younger individuals who are really low risk for surgical intervention, where we think that an initial strategy of a surgical valve replacement may be a better one than TAVR. But we struggle with this clearly. So where are we going with the interventions? We all know the randomized clinical trials that have led to our current recommendations going from prohibitive risk to low surgical risk. As indicated, we now have trials for asymptomatic patients. Both the early TAVR trial and the EVOLVE trial will be presented in the fall at TCT. So these could be, revolutionary, depending upon their outcomes. Could lead to early intervention, even in asymptomatic patients. We look forward to seeing what the results of this trial would be. Could be game-changing. There's other game-changing thought processes out there and clinical trials underway. How about patients who have reduced ejection fraction from a cardiomyopathic process and have moderate aortic stenosis? Maybe that degree of pressure overload for an already sick ventricle may be too much extra work on that ventricle. And so we have the TAVR Unload trial that's underway as well. And finally, how about patients who have only moderate aortic stenosis? I mean, we have these arbitrary definitions of what we think is severe aortic stenosis. And some patients may have, much more going on in terms of the physiology of their valve and their ventricle and their symptoms, who have what we think is only moderate aortic stenosis. And so the PROGRESS trial is underway as well. So any one of these, if positive and giving us a signal that earlier intervention and using a less invasive technique like TAVR could be clearly, game-changing for a number of patients who've got severe or less severe aortic stenosis. So where are we going? How about developing TAVR devices for aortic regurgitation? There's suddenly a great interest now in aortic regurgitation, moving beyond just aortic stenosis, because now we have devices. Okay, if we have the devices, which is the best device for which patients, and when do we have the right thresholds for intervention? Medical therapy is to slow progression of aortic valve disease, treat the valve, treat the ventricle. Greater precision in selecting patients for intervention. I think we're still using a lot of just hopefully good clinical judgment based upon what we believe we know, realizing there's a lot we don't know. How about using more advanced imaging, biomarkers to identify which patients are progressing more rapidly than others who might be good candidates for earlier intervention. And then we're getting into the era of artificial intelligence also, both in terms of timing intervention based upon pulling together all the information we have, aiding in device development, and also achieving greater precision in matching the right patient and the right device. And so if you've been following this field, along with everything else going on with AI, one sees a growing literature on the use of artificial intelligence, both for clinical decision-making and also looking for which patients with aortic stenosis are progressing more rapidly or have more severe aortic stenosis than others. And so I'm going to conclude with one final slide that I grew up with, not the slide, but the paper from Paul Wood. Paul Wood was a seminal cardiologist of his era in London in the late 1950s. And when I was a student, I was asked to read this manuscript. It's beautifully written, great English from Dr. Wood. This is actually the first volume of the American College of Cardiology's journal, which then was the American Journal of Cardiology. So it's in volume 1 of the AJC, where he starts out his treatise by saying aortic stenosis is a simple mechanical fault which, if severe enough, imposes a heavy burden on the left ventricle and sooner or later overcomes it. It's beautifully stated. That's true to a point. What's not true is that this is not simple anymore. This is very complicated stuff in terms of identifying the patients, following the patients, knowing when to intervene, how to discuss that with our patients, and then choosing the right intervention. And then also picking up the pieces afterwards in terms of the follow-up of our individuals, especially younger individuals who may be getting bioprosthetic valves, either surgical or transcatheter, and then trying to aim our sights at what is going to be our next intervention, should there be a need for another intervention in these patients. So it is complicated, and therefore it's quite interesting, and I think leads to increasing amount of enthusiasm and hopefully more good data coming our way in the future. So thanks for sticking with me for the discussion of my journey with aortic valve disease. I think much of that overlaps with yours, and I look forward to seeing new insights coming down the path as we go forward. Thanks again for the intervention, for the opportunity to be here and talk about our interventions for aortic stenosis and regurgitation. Thank you.
Do we have any questions from the audience? Just raise your hand, I'll come to you.
One here.
We have a question.
Excellent talk. I learned a lot. What is the role of aortic valve calcification in moderate aortic valve stenosis? And also you mentioned about the cardiac MRI. If you do an MRI in moderate AS, symptomatic patients, heart failure with preserved EF, if you see any fibrosis or increased ECV on the MRI scans, those patients should be sent to valve replacement, or in moderate AS with severe aortic valve calcification.
So this is where, thanks for the question, and I'll have to come back on the first one. The second part of the question, I think, will be helped by the Evolved trial So there's 2 trials coming out this fall in asymptomatic patients. The early TAVR trial is kind of all comers with asymptomatic severe AS. The EVOLVE trial comes from Mark Dweck and his group in the UK, and others, not just Mark, but they are doing MRI in their patients. And in order to be randomized, you have to identify some level of interstitial fibrosis. So that's going to help, I think, indicate where CMR could be useful. Once you start seeing fibrosis, is that an indication for earlier intervention? Because it's a signal that the myocardium is obviously under a lot of stress, a lot of hypertrophy, and that individual patient might be important. So I think we look forward to the results of that trial. But I didn't hear quite well the first part of your question.
There is some data. There is some data about the valve calcification score.
Oh yeah, thank you. Yeah, so I didn't mention CT scans. We talked about MRIs. Now, CT scans could also be very useful in evaluating, especially those patients who have low flow, low gradient aortic stenosis. I mean, is it really aortic stenosis? One of the first things we should consider doing is a CT scan and determining whether there's valve calcification or not. Because if the valve's not calcified, there's probably in middle-aged or older individual, it's not aortic stenosis. But then you could also do an aortic valve calcium score. A little bit of trouble with that because the scores differ between men and women, just as they would for coronary artery calcification. And if you look at the actual data, where you can look at the scatter of data between the patients with and without severe aortic stenosis regarding the calcification, if you're using calcification as a marker of severity of stenosis, it helps, but there's a great overlap when you look at the scatter of data between those who have aortic valve calcification and aortic stenosis, but it's moderate or mild relative to the ones who have severe. So it is helpful, I think, especially in those low flow, low gradient patients, just to define, is there aortic stenosis of any magnitude here or not? But in terms of grading severity, it's just another marker we use. I mean, we have to, when we see a patient with aortic stenosis, we're looking at all those things we get from echo or MRI, the gradient, the mean, the peak velocity, aortic valve area, left ventricular hypertrophy, left ventricular function. Okay, a lot of times we have to assimilate all that information. And other indices sometimes, like very severe calcification, could also help you.
Any other questions? I had a couple. I don't want to dominate if there are any other questions. So, Dr. Bonow, you obviously, the work on aortic regurgitation, seminal work that really has stood the test of time. And I made a couple of notes while you were talking. Okay, so where are we going? You talked about the volume indices. You talked about the regurgitant fraction kind of as evolving metrics, but you also, talked a little bit about biomarkers. What about things like biomechanics, strain, contraction patterns? And then what about the effect of exercise, where you also did a good bit of work on that earlier? As you said, you take and evaluate patients at rest. So a couple of words more about where our aortic regurgitation sort of parameters are moving towards in terms of assessment.
Yeah. Okay, great questions, Dr. Samity. So the second part we'll maybe do first. That's the exercise data. So this is a ventricle that's grown up wanting a lot of preload. That's how it can maintain systolic function. And when you exercise in patients with aortic regurgitation, you increase the heart rate, there's less regurgitant volume, so you have less preload. And you've got exercising muscle beds, which are getting all that forward flow. Another reason why you have less regurgitant volume is a function of the heart rate, where you have less diastolic time for regurgitation and more forward flow going forward instead of backward. So the ventricles get smaller. So those of you who've done either stress nuclear or stress echoes in patients with AR realize that the ventricle goes from a certain end diastolic volume at rest to a smaller end diastolic volume with exercise. So here's a ventricle that's grown up needing that preload, and now you're robbing it of preload during exercise. Is that good or bad? But that also means your ejection fraction may change. So the ejection fraction changes with exercise are very complicated. It's good if you do an exercise test, as Dr. Samadi suggested, and you find that indeed the ventricle gets smaller. That's probably the best indicator. Not so much what the ejection fraction is doing. If it doesn't get smaller, that may be an indicator of more severe disease. And so I think that's one thing. The other is the more complicated issue about, okay, what are the other metrics we could be using? Again, most of what we're dealing with are observational, retrospective studies, small series, single center. It'd be nice just to start pooling data in a prospective way. Some centers are starting to do that, but we haven't seen the data yet. Biomarkers are quite interesting. You could argue that BNP, which is a marker of stretch, is just telling you what you already know from an echo. The BNP is elevated in patients with aortic regurgitation because they have left ventricular dilation. And so BNP may not be a good marker. And yet there are data from South America demonstrating that the BNP could be used to identify patients who have more severe disease, even though most patients start out with an elevated BNP. If you stratify patients according to the level of BNP, it may be important. But again, I think we're across the board in cardiology still kind of limited with what we know about biomarkers and what else might be important, because there are emerging biomarkers looking at other indices of not only wall stress, but also fibrosis and other interstitial changes. So it's a matter, I think, of staying tuned. But it's again, you guys have the patients here, and so I don't mean patients with a CE, but patients with a TS. You have the patients here where you could begin to study these patients, and maybe we can get involved in some prospective registries of patients where we could begin to see what are the things that actually work. That's the nice thing about the early TAVR trial, because part of the early TAVR trial is a proteomics and a biomarker database. They'll be coming out in those asymptomatic patients with AS. So we're much further down the pike with aortic stenosis than we are with regurgitation.
Great. So Dr. Ramadan is our structural heart director.
Thank you, Dr. Bonow. It's a wonderful talk. A question I have is about what do we know about the outcomes of patients with mixed aortic valve disease? So if you have AS and AI together that do not meet the criteria for severe or for intervention, what do we do with those patients? And often they're, when we see them clinically, they're more symptomatic than even the patients with isolated disease. The second question I have, and just wondering what your thoughts are on this mechanism of diastolic flow reversal in the left main with severe AI. So as you know, there's a lot of patients with AI that have evidence of myocardial ischemia, but they don't have any coronary disease. And there's some older studies that I'm sure you're aware of showing diastolic flow reversal in the left main, and all kind of has to do with the hemodynamics of the flow and the turbulence.
Yeah.
And whether that is a population of patients that we should also focus on in terms of treating earlier that show those signs.
Great question. So Dr. Ramadan, I share your concern for both of those. First one regarding the issue of mixed valve disease. Yeah, there's not a lot of data. There's no good guidelines recommendations other than using clinical judgment. And what you usually recommend to simply, okay, which is this patient following, the pathway of aortic stenosis or the pathway of aortic regurgitation? Is the ventricle dilated or not? Is the ventricle hypertrophied or not? Which is what appears to be the more predominant lesion? That's not perfect at all. And I agree with you. You could have moderate one or the other, or moderate both, and the patient can be very symptomatic. And so, yeah, I think we need more information. This is where maybe other indices, again, MRI, biomarkers, et cetera, may be quite helpful. We have a paper, I'm part of a multi-center group that's got a paper being presented this week at the ACC using CMR in patients with mixed aortic valve disease. But that's so difficult because, when you have mixed disease, you have patients who've got a little more aortic stenosis, a little more regurgitation. And so, generalizing those data to individual patients, I think is going to be difficult. So again, right now we're going with clinical judgment. And I think in some patients, moderate AS, moderate AR is probably enough for them to be symptomatic. And I would certainly consider replacing the valve if nothing else pops up in our diagnostic evaluation of those patients. Regarding the flow reversal, it's very interesting. When you have ischemia with aortic regurgitation, is it, again, reverse flow? Or it could also be a microvascular disease related to left ventricular hypertrophy. We do know from data that have looked at myocardial ischemia in patients before and after valve replacement, the ischemia gets better or is reversed by aortic valve replacement. The tricky part there is how do you study those patients? Are they all going to get an invasive procedure to show the flow reversal? Can we image that with MRI or other techniques, maybe Doppler in some patients, tranthoracically or transesophageally? But we do know that simple stress tests, like a stress echo or a stress nuclear test, is very imperfect because a lot of patients who have asymptomatic disease from aortic stenosis or regurgitation could have abnormal perfusion studies and abnormal functional studies. But it's a great question. And, again, you may have symptomatic patients who have no coronary disease. Is this related to the valve or not? And, if the patient has myocardial ischemic symptoms, probably be recommending aortic valve replacement.
Well, great questions, and we're a few minutes after, so thank you all for your attention. Thank you for a fabulous talk. Anyone wants to come down and shake Dr. Bonow's hand, please stick around.